Hey, what's up? My name's Tyler Summer, and in this episode of MiniMedLessons, I'm going to talk about the basic principles of electrocardiography. This is the first episode in what is going to be a large master course series covering extensive detail about how to interpret EKGs here on my channel. So hang around, we're going to get started right now. So this is going to be the first video in what's going to be maybe 13 to 14 different videos where I'm going to go into great detail about how to interpret EKGs. I've been teaching how to interpret EKGs for several years now, and I'm really excited to finally make this YouTube course series for all of you. So I hope you enjoy. Whether this is your first time here or you've seen other videos that I've made, please take a minute and hit subscribe, hit that little bell notification thing so that you don't miss out on any of the upcoming videos. So electrocardiography, also known as ECG or EKG, is the process of recording the electrical experiences of the heart over a period of time. Now you might wonder, why do we have two different abbreviations for it, ECG or EKG? Okay, in the English language, we spell electrocardiography with a C. Okay, but in the German language, it's spelled with a K, and ECG sounds a lot like EEG. EEG is a somewhat similar diagnostic test that we use in neurology to look at electrical patterns over the brain, the surface of the scalp. And to avoid confusion, a lot of people, including myself actually, use EKG rather than ECG, but they're the same thing, interchangeable, so whether you say ECG or EKG, either one's great. So in order to record an EKG, electrodes are placed on a patient's skin in very specific areas and detect electrical changes coming from the heart's electrophysiologic pattern of depolarization and repolarization. I'm going to go into a lot of detail about how that works, some of that in this video and more so in episode 2, where I talk about recording an EKG and where the electrodes are actually placed on the body to record these EKG tracings. Okay. Now, EKG tracings have really been around and been studied since, I think, about the late 1800s. And the first portable EKG machine was actually invented in 1937. So in no ways is the EKG a newer diagnostic test, unlike things like the fMRI and some of the really cool diagnostic studies that are being used in new up-and-coming diagnostic studies. The EKG is a very old but very powerful diagnostic tool. It's one of the most useful diagnostic tools in many fields of medicine, not just cardiology, but also in family medicine, internal medicine, all sorts of different places. So here's an example of a 12-lead EKG. There are 12 different leads being displayed here on this printout, and if you've never seen an EKG before, this might look like just a bunch of squiggles and won't make a lot of sense. By the end of this master course series that I'm going to make here on YouTube, I feel confident in saying you're going to be able to look at something like this, a 12-lead EKG, and really write a paragraph or 2 or even 3 of narrative explaining what's going on in the heart physiologically, electrophysiologically. Okay. Now it's important to understand that the EKG specifically only measures the electrical impulses happening in the heart. We cannot use the EKG to diagnose things like murmurs or anatomical damage or congenital defects or things like that. Although, that being said, as you'll see in future videos, the EKG might show evidence of structural damage and structural changes, but there are other diagnostic tests like echocardiograms and MRIs, cardiac MRIs, that we might use to look at more structural things. The EKG is specifically for looking at electrical impulses as they occur throughout the heart over a period of time. Although EKG tracings can be pretty intimidating when you're just starting to learn how to read them, I feel pretty confident in saying that you'll learn how to read 12-lead EKGs and rhythm strips with ease if you participate fully in this master course series. EKG tracings can provide very helpful even critical information when it comes to making a diagnosis for a wide range of clinical situations. So with one glance at an EKG, you'd be able to diagnose serious myocardial infarctions, identify life-threatening arrhythmias, notice the chronic effects of something like long-standing hypertension on the heart, or the acute signs of something like a massive pulmonary embolism, or even just provide reassurance to someone who's wanting to start an exercise program at home. As you may already know, electrical impulses move through the heart in a very specific and predictable way if the heart is fully healthy without any structural or electrical problems. So understanding at least the basic anatomy of the human heart is vital in order to be able to interpret EKGs. So I want to show you some of those vital things that you need to understand, at least the electrical conduction system that exists in the heart. All right, so here's a drawing of the heart, and I want to show you some of the important structures here, okay? So first of all, right here we've got our right atria, our left atria, our right ventricle, and our left ventricle. So it's important to understand there are 4 chambers of the heart. Now this is a pretty simplified drawing of the heart. It doesn't include most 2 of the heart valves and the way that the heart really lines up in a 3-dimensional structure, but I drew it this way so that you can understand, okay, there are 4 chambers and where are the electrical structures here. Okay, so hopefully you're feeling comfortable so far. Now here in the right ventricle, in the posterolateral wall of the right ventricle, lies a structure that's not really identifiable to the eye called the SA node, or the sinoatrial node. Now the SA node, sometimes called the sinus node, the sinus, is where normal electrical conductions of the heart usually begin. Okay, so if the heart is functioning the way it normally should, that is where electrical impulses start. Also within that right atrium, but down in the bottom component, near what we call the septum, okay, this little structure here is called the septum, the wall that splits the 2 atria, there is another node here, electrical node, called the AV node, or atrioventricular node, because it lies near this junction of the atria and the ventricles. Okay? These 2 nodes are very important in the electrical conduction system. Now there are certain pathways known as the internodal pathways, because they connect these nodes, that help conduct the electrical impulse throughout the atria. Okay, and that electrical impulse, these internodal pathways, help to allow the electrical impulse that begins in the SA node to quickly, very quickly, pass to the AV node. Oh, excuse me. Let's fix the color. Now the AV node receives that electrical impulse, and there is a small little pathway here, the penetrating fibers into the bundle of His, that then go into the ventricles, into the septum between the ventricles. And there's a right bundle branch, and a left bundle branch that split off here high up in the septum, where the electrical impulse is then distributed very, very quickly throughout the ventricles. I'll talk a little bit more about that in the future, but for our purposes here in this first video, understand we've got the SA node, the AV node, the internodal pathways that connect the SA node to the AV node, a penetrating section that moves down through this atrioventricular junction that separates the atria and the ventricles, and then the right bundle branch, the left bundle branch, and out here on the end we have what we call the Purkinje fibers, which are part of this electrical conduction system where this electrical wave of depolarization moves the fastest. Okay, we'll talk more about that. Okay, so this atrioventricular junction that exists between the atria and the ventricles is where the valves of the heart, the 4 valves of the heart, reside, and the type of tissue is pretty fibrous, and so it actually acts as an insulator. So any impulse that starts here in the atria and spreads through the atria actually will not pass into the ventricles because of this insulator, this fibrous tissue that exists between the atria and the ventricles. The only place where it can actually pass through is right there at the penetrating fibers, the bundle of His. And that's very important for the normal electrical conduction of the heart. There are certain pathologic conditions that we'll talk about in the future, in future videos, future episodes, where there are what we call accessory pathways, where it bypasses this penetrating fiber and enters into the ventricles a different way. We'll get there in the future. But once this has moved down through the penetrating fibers and shoots down the left and right bundle branches, the ventricles are depolarized in many different directions all at once, essentially simultaneously. And it's the wave of depolarization that then results in depolarization of the actual muscle fibers, okay, that then result in the contraction of the heart muscle. And when we have disruption of any of these normal pathways, that's when we have different cardiac electrical disorders that arise, different types of arrhythmias or conduction defects, etc. We'll talk about how to identify all those throughout many different episodes in this series. All right, so there we go. I've cleared it up a little bit so that we've got a more clean version to work with as we continue our discussion here. So as you can see, we've got our AV node, our SA node, the internodal pathways helping to depolarize the right and the left atria, the penetrating fiber, and the bundle branches. Okay. Now, all of these structures make up what's called the electrical conduction system of the heart. And it's important to understand that these are not like neurons. While they do carry a wave of depolarization quickly through the tissue, it's different than a neuron with an axon, because with a neuron actually is one cell traveling a great distance. For example, a lower motor neuron that starts within the lumbar spinal cord, the lumbar segments of the spinal cord, will actually travel from that spinal cord all the way down into the leg, and it's one cell length. It's a long axon carrying that impulse. Unlike a neuron or a neuronal axon, these electrical conduction systems of the heart are actually chains of cells all lined up together with gap junctions that exist between these cells. Now, these cells are just specialized myocytes or cardiomyocytes, muscle cells that actually allow this electrical impulse to move quickly through them because of those gap junctions. And so we have three main types of cells involved in the cardiac electrical impulse. So we have pacemaker cells, which are these pacemaker cells are largely found here within the SA node. There are some pacemaker cells in the AV node, and there are pacemaker cells that exist down into the Purkinje fibers. And we'll talk about when those different pacemakers take over. But in a normal, healthy heart, a normal situation, it's the pacemaker cells of the SA node that are acting as the conductor to the rate of the heartbeat. Okay, so pacemaker cells, and under normal circumstances, these are the power source of the heart, where the electrical impulse originates. Now then there are electrical conducting cells. These are the ones that are all lined up in chains, like these internodal pathways and the bundle branches and the Purkinje fibers. These are these electrical conducting cells, and like I already mentioned, these are basically chains of cells connected with gap junctions to allow for that wave of depolarization to move quickly along those cells. And then you have your myocardial cells. These are the cells that make up the normal walls of the heart. And these are capable of being depolarized, but because they are different than those that make up the electrical conducting pathways, the wave of depolarization moves a little slower through those cells. And these are the main contractile machinery of the heart. So when they are depolarized, they contract, resulting in that overall contraction of the heart and pumping of blood. If you're rusty in your cardiac anatomy and physiology, it'd be pretty important to review that type of information so that you can more fully understand and comprehend EKGs. Now, depolarization is the fundamental electrical event of the heart. And once an impulse is initiated by pacemaker cells, such as those that exist here in this SA node, the depolarization wave propagates from cell to cell, moving through the myocardium. Okay, a lot like this. A lot like ripples in a pond. Okay, so think of standing at a pond or a lake and throwing a rock into the water, and it creates this ripples that spread across the surface of the water. Okay, it's a lot like that. Now, the impulse is going to move a lot faster down those electrical pathways, like the internodal pathways, but it's still going to spread over the myocardium as well. And remember, like I mentioned on a few minutes ago, that there is this fibrous tissue barrier that exists between the atria and the ventricles that prevents that that initial atrial wave of depolarization from moving into the ventricles. Okay, so this wave of depolarization moves across those cells, depolarizing the cells as they go. All right, so let's spend a couple minutes talking about depolarization and what actually is happening physiologically. So if you look here at the screen, we've got this blue box is representing a cell, or a myocardial cell in this case, and the negatives signs on the inside represent a negative overall internal charge of the cell, more positive on the outside, more negative on the inside. And if you think back to your physiology courses, that should make a lot of sense, because the normal resting membrane potential of a cell is negative on the inside, positive on the outside. Now, when a cell is depolarized at a specific spot on that cell, positive charges from the outside of the cell are allowed to move into the cell, now causing that section of the cell to be depolarized, or more positive on the inside. Okay, and so now it's more positive on the inside and more negative on the outside. And because of the way certain voltage-gated channels react to that change in charge across the membrane, channels open, and this more positive charge is able to propagate down the cell membrane, causing this wave of depolarization to move down the cell, so impulse propagation. And so the cell is rapidly depolarized, and in the case of the heart, it'll move from cell to cell to cell because the cells are interlaced in a lattice network connected with gap junctions. And so you get this impulse propagation, and then the cell will quickly repolarize after that wave of depolarization has moved through, especially utilizing these sodium-potassium pumps, as well as some other mechanisms in order to repolarize the cell membrane, so that the cell is then reset and ready for another wave of depolarization to come through. Now, I don't want to go into any further detail than that in this video about the resting membrane potential and about depolarization, but if you're rusty on those facts, it might be worth refreshing your memory on some old physiology material. But that being said, if you understand it to this depth, you're doing okay, and you'll be all right for interpreting EKGs. Just understand that a depolarization wave can move across and down and through cells, and then the cells will then repolarize after a short refractory period. Now, electrodes can actually be placed anywhere on the surface of the human body and would be able to technically pick up the electrical impulses of the heart's activity. That being said, when we're recording 12-lead EKGs for very specific diagnostic purposes, we place these electrodes in specific places on the body, and we do it the same way every time so that we can predictably see what the electrical impulses look like from different angles around the heart. I'm going to go into a lot of detail about that and how we get 12 different leads on a 12-lead EKG and what each lead is actually telling us. Each lead has its own vantage point, its own point of interest from the heart. Okay, and we'll talk about that in video number 2 when we talk about recording the EKG. Now, each electrode detects impulses as the heart goes through its normal cardiac cycle, and each electrode records it from a different location. And then these different locations then result in the different tracings depending on the position. Again, I'm going to be going into that in a lot more detail in video number 2. Now, continuing our discussion of the basic principles of EKG, it's important to understand why we have positive or upward deflections on the EKG, why we have negative deflections sometimes, why we have more isoelectric or biphasic waves sometimes. So to help illustrate this, I'm going to pull in this old, horrible photo of me from several years ago as a body to be able to illustrate this principle on. So I'm going to go ahead and draw our electrodes here. So like I'll talk about next time in video number 2, we make up a lead by having one of the electrodes be positive and one or two be negative. And the positive electrode is going to be the one that's actually recording the electrical impulses. Don't worry about that in too much detail right now. We'll talk about that next in the next video. But let's say here, for the sake of this discussion, we've got a lead that's recording from my left shoulder. Okay, and so it's recording directly from that direction. Now, if we have an electrical impulse moving through the heart that is moving exactly that direction, straight from my right shoulder to my left shoulder, okay, in the same direction that lead is recording from, then the impulse recorded on the EKG is going to be a strongly positive deflection. So a wave of depolarization moving directly towards a positive electrode will cause a positive deflection on the EKG tracing. Now, similarly, if we have an impulse that's traveling towards the electrode but not necessarily straight at the electrode. In this case, it's moving down a little bit. It's still moving to my left, but it's moving down as well. Then we're still going to have a positive deflection on the EKG tracing. It's just not going to be quite as positive. Okay, hopefully that makes sense. Now, same idea here, except if we have the impulse moving directly away from the electrode that's actually doing the recording, we are going to get a deflection, but in this case it's going to be a negative deflection. A wave of depolarization moving directly away from a positive electrode will cause a negative deflection on the EKG tracing. And just like we talked about on the previous slide here, if the impulse is moving, again, away from it, but not exactly away from it, not exactly the opposite direction, then we're still going to get a negative deflection. It'll just be less negative than if it were moving directly away from the electrode. Okay, hopefully that makes sense. Now, what if the impulse is actually moving perpendicular to the electrode? It's not necessarily moving towards it, it's not necessarily moving away from it. Okay, in this case, the EKG tracing is actually going to record what we call a biphasic wave, or maybe an isoelectric wave where there's not much of a tracing to be recorded. Okay, and the reason for this is, if you look at the cursor here, as the impulse is traveling this direction, it's moving towards that positive electrode, not directly at it like this, but it's still moving towards it. So we get a little bit of a positive deflection. And then as it passes that line and is now moving away from it, not exactly away from it, but away from it, we get a little bit of a negative deflection. So as the impulse moves perpendicular to that recording electrode, we get a biphasic or isoelectric wave. Now, if this information about positive deflection, negative deflection, impulses moving towards it, away from it, is kind of confusing, don't worry too much, because it's going to become a lot more clear as we continue moving through this series. But for now, understand that if an electrical impulse is moving towards an electrode, we'll get a positive deflection. If the impulse is moving away from the electrode, we'll get a negative deflection on the EKG tracing. Now, the waves that are recorded on the EKG tracing are primarily reflecting the electrical impulses that are happening within the myocardial cells, basically because the bulk of the heart is made up of this contractile myocardial tissue. Okay, and so the impulse that comes from the SA node, the AV node, those places, is not a whole lot of electrical current, And so the bulk of this electrical activity is actually happening in the myocardial cells. And the waves that are produced by this electrical impulse, the depolarization and then the repolarization of the myocardial tissue, is recorded on special EKG graph or grid paper. There's some important things to understand about EKG paper and the grid that exists on that paper. So the horizontal axis on this grid paper is the duration of time in seconds. All right, so as we move along the paper, horizontal axis, it is time measured in seconds. The vertical axis, up and down, is actually the amplitude of the impulse or of the tracing, and that's measured in millivolts. And so here you can see this is an example of the EKG paper. You can see it's a nice grid pattern, 5 by 5 large boxes made of these small boxes. Okay, amplitude in the vertical axis, duration in seconds along the horizontal axis. A few other things to know about this EKG paper and the way it's printed is that the EKG paper prints actually at 25 millimeters per second. Each small box on the grid paper is 1 millimeter. So every second it prints 25 of those little boxes along the horizontal axis. So 25 millimeters is 1 second of time. Okay, and the EKG paper is marked every millimeter, and we can call those little boxes, and every 5 millimeters, which I like to call the big boxes. Okay, so let me show you again on this grid paper what that looks like. So as you can see, we've got the big boxes here, and we've got the little boxes. So one little box is 1 millimeter, and one big box is 5 millimeters. All right, so because along this horizontal axis we're measuring time in seconds, we can also say that 1 millimeter is technically 1/25th of a second, or 0.04 seconds, while 5 millimeters is 5/25ths of a second, or 0.2 seconds. And that actually is important to understand. So one little box, 0.04 seconds, one big box, 0.2 seconds. And that does make a difference and is important to understand, especially when it comes to measuring heart rate and things like QT prolongation and other abnormalities that we'll get to in future units. This also means that every 5 big boxes equals 1 second, and 30 big boxes equals 6 seconds. And you might say, well, when would I ever need to know 30 big boxes is 6 seconds? Okay, and you'll see in the third video where we talk about rate and regularity, it is important to be able to know, okay, across 6 seconds, that's 30 big boxes, and that's going to help us sometimes determine the heart rate. And you'll see when that's applicable. So let's apply that here on this grid paper. You see, I'm going to throw a fake tracing here in the red. You can see, okay, we've got 2 waves here, one half as tall as the other in amplitude. And duration-wise, these are both the same. And because they are 5 little boxes, okay, in other words, one big box, we know that these waves are 0.2 seconds in duration. And if we start from the beginning of the first wave to the end of the second wave, that's actually 5 big boxes, which we know to be 1 second of time. And again, the amplitude it depends on the setting of the EKG machine, so don't worry too much about this 0.5 versus 1 millivolt, because you can actually change that on the machine. But just understand that, you know, we could say that the second wave is twice the amplitude of the first wave. Don't worry too much about the amplitude right now. Amplitude becomes much more applicable when we're looking at things like hypertrophy and enlargement, which is going to be one of the last episodes in this series. For now, let's focus mostly on duration in seconds along the horizontal axis. So as the heart moves through one cardiac cycle, where it's depolarizes, contracts, repolarizes, and relaxes, okay, one cardiac cycle, the EKG records that whole event with a tracing that is characteristic and predictable if the heart is healthy and functioning the way it's supposed to. On a 12-lead EKG, we generally like to use lead 2 as a rhythm strip. Okay, because lead 2 often is the one that presents that characteristic or textbook-like appearance of the EKG tracing. That's not always the case, however. It depends on the person's own physiology. Maybe they've had some heart damage, and so lead 2 doesn't give us the nicest tracing. But for the most part, lead 2 gives a nice, clean tracing that is easily recognizable and we can use to determine the rhythm. Okay, and we also, in the hospital setting, like I'll talk about in the second video with recording the EKG, we might not get a full 12-lead EKG. We might just get a rhythm strip, which is one lead, or we might get a couple of leads to look at for a lot longer duration, more than 6 seconds like we might get with a 12-lead. And we call that a rhythm strip. Paramedics use that a lot when they're in the field. We use it a lot on cardiac units in the hospital when we're monitoring a patient for arrhythmias. So, we're going to focus a lot on lead 2 as we move into the arrhythmias in future episodes, because that gives us this characteristic EKG tracing of the cardiac cycle. So you'll see why in the future. But for now, let's focus in on one cardiac cycle and follow that cycle through and see the electrical events that produce that standard EKG tracing, the waves, complexes, and segments and intervals that make up a standard EKG tracing. All right, so let's go back to this drawing here, and we're going to talk about the different waves and such that we see as these electrical events are occurring in the heart. So when the SA node fires, right here at the SA node, okay, and remember this occurs spontaneously, and the SA node firing is actually not visible on the EKG. The SA node is so tiny, made of just a small collection of cells, that the actual electrical current that SA node creates is not something that spikes up on the EKG. Instead, what we see starting is this wave of depolarization moving through the atria like this, creating what we call a P wave. Okay, and so this wave of depolarization begins there at the SA node, and it spreads outwards like ripples in a pond into the atrial myocardium. And we've got that fibrous tissue, remember, that's blocking it from moving into the ventricles. So the average of the electrical vectors moving through the atrium is then recorded on the EKG tracing as a P wave. Okay, and like you can see here, it's not a very big wave, but it does occur, and that P wave represents atrial depolarization. And because the right atria depolarizes first, simply because the SA node is in the right atria, the first half of the P wave predominantly represents the right atrial depolarization, while the second part is representing the left atrial depolarization. So now, because of these internodal pathways, that wave of depolarization actually reaches the AV node very quickly. At this point, however, the conduction is slowed and delayed there at the AV node. It almost halts right there at the AV node and doesn't move directly into the ventricles at that time. There's a pause, there's a delay. You might be wondering, well, why or how? I don't remember what that is. And the main reason for this is the electrical conduction cells that make up the AV node have far fewer gap junctions that exist between them. So the electrical conduction slows down and doesn't move through that tissue nearly as quickly. And so you get this pause on the EKG tracing. And so this conduction pause right after the P wave before ventricular depolarization is allowed to occur. So this delay in the recording on the EKG tracing is what we call the PR segment, and it's immediately following the P wave. We'll talk more about what we call the PR interval here in a couple of minutes. So as soon as that wave of depolarization is able to escape the AV node after that delay that has occurred, it moves through the penetrating fibers here into what we call the bundle of His, and then is able to now depolarize the ventricles.
Now, that wave of depolarization is going to move very quickly down the right and the left bundle branches and Purkinje fibers, almost instantaneously reaching everywhere in the ventricles all at the same time. And so the ventricular depolarization happens very quickly, and for all intents and purposes, all areas of the ventricle depolarize at the same time, simultaneously. So it's a very complex wave of depolarization coming from many different locations. Now, the right bundle branch depolarizes the right ventricle, and the left bundle branch depolarizes the left ventricle. Notice as well, if I back up a little bit here, I made a little bit of a mess, huh? If I back up, this left bundle branch also includes what we call a septal fascicle, where rather early in the left bundle branch, there's a little branch that breaks off and depolarizes this septal wall. So we've got the left bundle branch that is separating fairly early and depolarizing the septum, and it also has fascicles, because remember we're looking at a three-dimensional structure, not a two-dimensional structure, so we have anterior and posterior fascicles as well. Don't worry much about the left bundle branch's fascicles right now. We're going to get into that in the future when we talk about hemiblocks and fascicular blocks. That'll be one of the last videos in this series. But for now, this wave of depolarization goes into the ventricles very quickly, causing just a almost instantaneous depolarization everywhere in the ventricles all at once, and this results in what we call the QRS complex on the EKG tracing. Because the ventricles are so much more massive in tissue size, the ventricular depolarization wave is of much greater amplitude than the P wave on the tracing, as you can see here. And it's simply because the ventricles have more muscle mass. More tissue is being depolarized. It's being depolarized rapidly and aggressively all at the same time. So you get a big amplitude wave that happens very quickly and suddenly. The QRS complex is more complicated and variable in shape because the depolarization pathways in the ventricles are more intricate and more complicated than what we see there in the atria. So the appearance of the QRS complex can actually vary quite a bit depending on what lead you're looking at. And we'll talk about that more in the future. And you'll see once we start exploring 12 leads that a QRS complex looks very different in one lead compared to a lead looking at the heart from the other side. Okay, don't worry about that too much right now. Now, there are some other important things that we need to talk about when it comes to the QRS complex. QRS, okay, a Q wave, an R wave, an R wave, and an S wave is what you would assume makes up a QRS complex, right? But it's not always three separate deflections. And so it's important to be able to name and understand what you're looking at when you look at these different QRS complexes and different leads. Now, we're still going to call all of these variations of a QRS complex the QRS complex, but there are some important rules about naming these waves within the QRS complex that you need to know. Now, it's important to understand the first rule here is if the first deflection of the QRS complex is downward, we call it the Q wave. Okay, so first deflection, if it's downward, Q wave. The first upward deflection is always called the R wave. It doesn't matter if it's the first deflection, but it's just whatever deflection is upward, the first one that goes upward, that's the one we call the R wave. It might be the first deflection of the QRS, or it might follow a Q wave. The first downward deflection after the R wave is the S wave. So notice, it's important to understand a Q wave is always downward, an R wave is always upward, and an S wave is always downward. But an S wave follows an R wave, and an R wave is always the first positive deflection, whether it's happening before any other wave in the complex or after a Q wave. Now, if there's a second upward deflection after an S wave, we call that second upward deflection R prime. Okay, I'll show you an example of that here in a second. If the entire QRS complex is down, a downward deflection with nothing that comes up above the isoelectric line, then it is called a QS wave. Okay, so let me show you some examples here. This wave here, we've got a downward deflection, a upward deflection, and a downward deflection. Because we've got a downward deflection first, followed by a positive deflection and then a negative deflection, we call this a QRS. So this is the classic characteristic QRS complex. Now, in this example here, you see that the first deflection is positive, it's upward. So the first upward deflection above the isoelectric line is always called the R wave, and then a negative deflection after an R wave is called the S wave. So in this example, this QRS complex could be labeled an RS wave. We still call it the QRS complex, but if we need to get specific for any reason, we would call it the R wave and the S wave. In this example, there is no positive deflection. The whole thing is down. We can't really call it only a Q wave. We can't really call it only an S wave, so we're going to go ahead and call it a QS wave. There is no R wave. Again, though, it is a QRS complex. We just call this specific type of QRS complex a QS wave. In this example, there's only one deflection upward. Because a Q wave and an S wave are both downward deflection, there is no Q wave or S wave in this case, so this is simply an R wave. It is the QRS complex, but it's just an R wave. In this example here, you see our first deflection is downward, so we call it a Q wave, followed by a positive deflection, so that's an R wave. There's no S wave, so this is a QR wave. And in this example, our first deflection is positive, so that's an R wave. Then we have a negative deflection, and even though it doesn't get all the way down to the isoelectric line, it's still what we would call an S wave, followed immediately by another second upward deflection, and we'd call that R prime. So this is the example of RS R prime. And you'll see that RS R prime is very important to be able to identify quickly when we get into certain conduction defects, specifically a right bundle branch block. Don't worry about that right now, just understand that that type of a wave for a QRS complex is what we would call an RS R prime. Now, the initial first part of a QRS complex is septal depolarization, because really the first thing being depolarized in the ventricles is the septum, right? And so we sometimes see that as a small little Q wave. So if we see in our QRS that we have a small Q wave before the R wave, that is known as the septal wave, or evidence of the septal depolarization. Okay. In the future, we're going to talk about what we call pathologic Q waves. Don't worry about that right now, but know that not all Q waves are normal. Sometimes a Q wave will look a certain way, have certain characteristics that make it pathologic or evidence of something that's gone wrong there in the heart. So we'll talk about that more in the future, especially when we're talking about ischemia. Now, because the electrical impulse moves so quickly down the bundle branches and the Purkinje fibers there in the ventricle, the ventricular depolarization event happens so quickly that the QRS complex actually only lasts less than 0.12 seconds. Okay, which means a QRS complex is normally less than 3 little boxes in duration. That's important to understand, because at some point we're going to be looking at the duration along the horizontal axis of the QRS complex. A normal QRS complex is less than 3 little boxes, or less than 0.12 seconds. Now, obviously, as you've probably figured out by now, the QRS complex starts with the first positive or negative deflection that occurs after the P wave. Okay, but the QRS ending point is sometimes a little harder to see, but we call that ending point the J point. Sometimes it's quite obvious where that QRS complex ends, sometimes it's not as clear. But either way, the last spot on a QRS complex we call the J point. Because finding the J point can be a little tricky sometimes depending on the shape of the QRS complex, there's one semi-simple rule that you can use to try to decide, is this where the QRS complex ends? Okay. There's normally not a curving elbow inside of a QRS complex. So if the QRS complex seems to end with a curving elbow, the J point is at the beginning of that curving elbow most of the time. Okay. That being said, if you're having a hard time deciding where the J point is in one lead, take a look at the other leads. It might be obvious as can be in a different lead. Don't worry about figuring that out right now. I'm going to show you lots of examples of that in the future, in future units, especially when we're looking at the duration of that QRS complex. After the ventricular myocardial cells have been depolarized by that rapid wave of depolarization, they pass through what we call a brief refractory period. This is where the cells are in a state of depolarization and moving into repolarization where they can't actually be depolarized again. Okay, and so there's a pause between depolarization and repolarization that occurs. Sodium-potassium pumps start working then, exchanging those ions to help establish again that resting membrane potential, but there's that refractory period before that repolarization occurs. The repolarization, as it's occurring, again causes, because the ventricles are so massive, causes a shift of current. And so we can actually see evidence of ventricular repolarization on an EKG. And it's picked up as a tracing that we call the T wave. So a T wave on an EKG is ventricular repolarization. Okay, so you might actually ask, well, the atria have to repolarize, right? Do we see any wave that indicates atrial repolarization? And the answer is no. Okay, the atria, notice the atrial depolarization with the P wave it's quite small, and because there's not a lot of mass or cells there that make up, the walls of the atria are quite thin. And so we do see the depolarization because it generally happens when nothing else electrically is occurring. But when the atria are repolarizing, that is such a small electrical event, and it generally occurs when the QRS complex is happening. So it gets lost in the QRS complex and doesn't cause much of a tracing anyways. So we see atrial depolarization, ventricular depolarization, and ventricular repolarization. P wave, QRS complex, T wave. Now that we've talked about the various waves and the complexes that we see, the P wave, QRS, and T wave, let's discuss the straight lines, because we've named these waves now, right? We've named P wave, QRS complex, and T wave, but what about the straight lines that exist between them? Okay, so a segment is a straight line that connects two waves. So as you can see here, this little segment connects the QRS complex and the T wave. It is between the two. It doesn't involve the two, it's just between the two. An interval, on the other hand, is a straight line that encompasses at least one wave plus the connecting straight line. So example here, this interval that's marked here on the graph shows the P wave and the segment that exists after the P wave. So that's known as an interval. So a segment does not involve a wave, an interval does involve a segment and at least one wave. Okay, notice these are both along the horizontal axis, so intervals and segments are duration in time. There are several important segments and intervals that you need to know, and I'm going to show those to you on the next slide. And the reason these are important to understand is because we look at these segments and intervals when we're trying to determine if the patient has conduction defects, if they have an arrhythmia, or if there's any evidence of ischemia. So it's important to know the names of these intervals and segments. So first of all, we have the PR interval. It includes the P wave and the PR segment that follows the P wave. So this is the duration of time from the start of atrial depolarization, from the moment that P wave begins, to the start of ventricular depolarization. So it includes all of atrial depolarization and the pause that happens at the AV node, but does not include anything after the beginning of ventricular depolarization. It's important to know the duration of the PR interval is normally 3 to 5 little boxes, or if we put that in seconds, 0.12 to 0.2 seconds. We're going to bring that up again when we're talking about conduction defects, because when we talk about AV blocks or blocks that occur in that AV node, that affects that PR interval because it involves the PR segment where that pause is happening. Another straight line we need to know about is the ST segment. The ST segment is the time between ventricular depolarization and repolarization. So it's the time when the ventricular myocardial cells are in that refractory state. And it's especially important when we start talking about ischemia, because we'll talk about something called an ST elevation myocardial infarction. Myocardial infarction being a heart attack due to blockage and ischemia that's occurring, and that ST segment will elevate in an ST elevation MI or a STEMI. Okay, so we'll talk about that during our ischemia episode. Another interval that you need to know is called the QT interval. This is the duration of time from the start of ventricular depolarization to the end of ventricular repolarization. So notice this interval not only includes one wave, but a second wave, as well as a segment. So we've got the QRS complex, the ST segment, and the T wave all being included in what we call the QT interval. The QT interval is especially important because there's a condition known as QT prolongation, and so we need to be able to accurately determine if the person's QT interval is appropriate for their heart rate and gender. And there's a little calculation that I'll give you in a future video that's called the corrected or calculated QT interval, or the QTC. So more to come on that. For now, simply understand we've got the PR interval, what that represents, the ST segment, what that represents, and the QT interval. Of these right now, know the PR interval is that 3 to 5 little boxes. All right, we're nearing the end of video number 1. Can't believe it. So here we go. Let's quickly recap what we've covered in this video so far. So if you look over here on the left cardiac cycle, we've got the P wave, which again is representing atrial depolarization. That pause that occurs because of the slowing that happens at the AV node. Ventricular depolarization represented by the QRS complex. And remember, this QRS complex can take on all sorts of different shapes. And then we've got a pause that happens after that with the refractory period. And then we've got the T wave, which represents the repolarization of the ventricles. Notice it is longer in duration than the QRS complex. So that what you should take away from that is the QRS complex, or ventricular depolarization, is much faster in time. So it takes less time to depolarize the ventricles than it does to repolarize the ventricles. Okay, so atrial depolarization, ventricular depolarization, ventricular repolarization. If we look at our important segments and intervals, we've got our PR interval, including the P wave and the segment. And then we've got our ST segment, that's the refractory period, becomes very important when we're talking about ischemia. And then we've got the QT interval, that is the QRS complex, ST segment, and T wave all together. So the QT interval represents the electrical activity within the ventricles, and we're concerned with the duration of time there. You'll see that more in the future. Now, there is one other interval that we haven't talked about quite yet that is called the R to R interval. So R to R interval is from one QRS peak to another QRS peak. Now, depending on what it looks like, if you've only got a rhythm strip and there's only a downward peak, only like a QS wave for the QRS complex, just use that peak. But the main idea here is from one QRS to the next QRS peak, the duration of time between those two QRS complexes from the peak to peak is the R to R interval. We're going to apply that in the third video when we talk about heart rate and regularity. All right, well, that wraps up our first episode in this EKG series. I hope you found it helpful and clear and easy to understand. Like I mentioned early in the video, there will be about 14 different videos in this course series here that I'm going to be creating. And so because I'm creating so many, don't forget to hit that subscribe button and that little bell notification so you get notified every time I upload a new episode.
If you liked this video, please hit that thumbs up, share it with your friends, maybe classmates, other providers if you're a provider, and tell me what you thought in the comments. Tell me if you have any questions. I hope you enjoyed it. I hope you found it to be helpful. So please let me know. So I'll see you in the next video where I'll be talking about recording the EKG, and I'll talk about all the differences between the different leads on a 12 lead, as well as the difference between a 12 lead and a rhythm strip. So thanks for watching. See you in the next video.